Hello, and thank you for joining me on this IPCRG Difficult to Manage Asthma case study. This relates to the Difficult to Manage Desktop Asthma Desktop Helper number 2. This is a case study looking at the role of biologics in difficult to manage asthma. The patient name is Bernadette. My name is Gary McDonald. I'm a respiratory pharmacist in Scotland, and I was working with my colleague Professor Liam Heaney in Northern Ireland on this. You can find the desktop helper at the link below there. That's ipcrg.org/DTH2. It's a small and concise 4-page document looking at how to identify a patient with difficult to manage asthma, what you should check when conducting a structured review, and when to refer for specialist assessment. Here's a QR code for this. Don't worry, I will show it again at the end. This is a simple way just to find the desktop helper. But remember, I will show again at the end for you if you got your phone ready. Okay, the learning objectives today, we're going to look at what is difficult to manage asthma, how you can identify what cohort of your patients have difficult to manage asthma. So we know in the UK there's between 5 and 10% of patients that have asthma have difficult to manage asthma. And we also know about 25% of them are being managed correctly. The others aren't being reviewed or aren't being seen at all. So it's a really important cohort of patients. We're going to look at the confounding factors and understand about confounding factors in asthma diagnosis and how these factors can mask the diagnosis of asthma, but they can also mask the severity of the asthma as well. So it's not just about getting the right diagnosis, it's making sure that once we've got the right diagnosis, that we're seeing how true and how severe the asthma is. We're going to look at the risks of uncontrolled asthma, but we're also going to look at the risks of the management of asthma as well. Uncontrolled asthma carries the risk of exacerbation, hospitalisation, and death. But the inappropriate management of this with high-dose inhaled corticosteroids and oral corticosteroids also carries a risk too. We'll be talking about how to conduct a structured asthma review, which is a regular and planned structured review. It's the only way to improve the detection and care of people living with difficult to manage asthma. And we'll look at when to refer for specialist assessment. At what stage should you refer, and what you should do before referral, and what to convey in that referral letter. So the desktop helper sets out what you should check when conducting a structured review. We want to be looking at, is the patient's asthma controlled? Are they still smoking? Patient education and self-monitoring, are they aware of their asthma? Are they using peak flow diaries? Are there other factors that are aggravating the patient's asthma? Are there other things that are triggering the patient's asthma? We need to look at, is the patient's inhaler technique optimal? Is the patient using the inhaler? They might have the best inhaler technique in the world, but if they're not using it regularly, does the patient have obesity? This can also be a factor in asthma as well, and this pops up in our patient we're looking at today. Will the patient require some psychological support as well? One thing we often overlook with our asthmatic patients. And specifically for this case study, we'll be looking at the referral for specialist assessment, looking at when to refer for the patient as well. So this is Bernadette. She's a 42-year-old woman, diagnosed with asthma in 1999 in another practice. So she wasn't diagnosed in our practice, not necessarily by anybody that's working here today. She's a non-smoker. Her weight's 90 kilos. Her height is 154 centimetres, giving a BMI of 38. She's recently registered with this practice because she's moved from another area for a new job. She was self-employed previously in IT, but now has a permanent job. And this is a really important thing for Bernadette. She doesn't want her asthma to interfere with her new job. So how did Bernadette present to us? So, as a new patient with a current asthma diagnosis from another practice, an annual asthma review was requested with the patient upon registering. That's vitally important. We need to make sure that the patient definitely has asthma. Just because somebody's diagnosed it previously, and in this case in another practice or with another physician, we need to make sure they definitely have asthma. She was requiring a prescription for further supplies of her medication for her asthma. And we need to confirm a diagnosis and the appropriateness of pharmacotherapy to identify her triggers and manage her concerns based on her understanding of asthma as well. Her biggest concern was getting her asthma controlled as she was previously self-employed. She doesn't want to lose her new job, so we've got a patient goal there right away. Looking at her medical history, in the previous 12 months, she's had 3 admissions to hospital and then admission to ICU, intensive care unit or intensive therapy unit, which required ventilation. She'd had 6 courses of steroids in 6 months and has persistent disabling symptoms. Her SABA use, or her short-acting beta agonist use on a when required basis, is very often, 4 to 5 times per day. And she also gets really disturbed night sleep because of her asthma. She has a history of anaphylaxis. We don't know what's caused it. She's had atopic eczema and hay fever from childhood, so we know this is not late onset asthma. She's had nasal polyps. She's had recurrent surgery, with the last surgery 2 years previously as well. So this is important because we know that nasal polyps and chronic rhinosinusitis with nasal polyps is common in about 80% of patients as well. Often overlooked because we don't think about it as a lung disease, when in fact it is part of the one airway. So what's Bernadette currently on when she's came to the practice? She's on a high dose inhaled corticosteroid and a LABA, long-acting beta agonist, combined together. She's also on a long-acting muscarinic antagonist that she uses once a day. She's on a topical corticosteroid nasal spray once a day. She's on a short-acting beta agonist inhaler when required. She's also on a leukotriene receptor antagonist once a day, slow-release theophylline, and oral prednisolone. Now, me as a pharmacist, I would be looking at this thinking we could certainly right away look to consolidate our inhaled medication to triple therapy. Now, that means moving from multiple inhalers, with such as an inhaled corticosteroid and LABA, and then a separate LAMA, combining them all together to triple therapy. Now, whatever country you're in, there may be a different licensing with respect to this as well for either COPD or asthma, but this would be one thing I'd be looking to do. Topical corticosteroid, ideal for her as well, especially with nasal polyps and possibly chronic rhinosinusitis. I'd be looking at her SABA use as well, that her initially what she was using 4 or 5 times a day. That's a red flag and an alarm to me. Her leukotriene receptor antagonist use, well, yeah, if the needs must and she's getting benefit from it, great. Looking at theophylline as well, personally, I'm not a big fan of it. In the UK, you can buy it over the counter in pharmacies. However, if you come into hospital, we would actually check your blood levels for theophylline because we tightly monitor it. And her oral prednisolone 7.5 regular maintenance dose as well. We know about the harm that long-term steroids can do to patients as well, so we're looking to reduce that where possible. On examination, we've already mentioned she weighs 90 kilos, 154 centimetres, giving a BMI of 38. Her ACQ score was 3.8 and her ACT score was 12. So her asthma's really not controlled, and she's telling us this. Her FeNO, that's the fractionated expired nitrous oxide, which comes from the eosinophils in the lungs. That's above a threshold, so that's 52 parts per billion. In spirometry in the practice, her FEV1 came out at 62%, so she's not getting the best out her lungs at all. We checked her inhaler technique, and actually it was pretty good, with a few minor corrections. Things like just holding your breath that little bit longer as well, and slowing the inhalation speed on her metered dose inhaler. She was currently symptomatic, and that's probably what drove her to the practice to register as soon as possible. Now, this is always a key thing with asthma. This is often when we see our asthmatics, we tend not to see them when they're well, but actually when we do see them well, if we were doing, say, peak flow with them or spirometry, you're not going to get a true reflection of what the disease is. So because she was currently symptomatic, I'm getting a true picture of what her asthma was like. So if we're looking at the desktop helper and using that to make a diagnosis, let's look at what that would be telling us. Does the patient have daytime asthma symptoms more than twice a week? Does the patient have any nighttime waking due to asthma-related symptoms? Is the patient having more than 2 exacerbations per year that require oral corticosteroids? Does the patient frequently use their short-acting beta agonist? And that means using 3 or more canisters a year or 3 or more times a week. And is there poor control despite prescription of high-dose inhaled corticosteroid in combination with the LABA and with a LAMA in her case, and oral corticosteroids? And is the patient a frequent user of primary care and out of hours? I mean, what that may mean more than one a month. Well, come back to the top. Yes, we do know her daytime asthma symptoms are more than twice a week. She is waking up at night and she's getting broken sleep because of that. She's had 6 exacerbations in 6 months. She is using frequent use of her SABA, far more than 3 times a week. She's using it probably 4 or 5 times a day. Looking at her here, does she have poor control despite being on high dose corticosteroid and the LABA and the LAMA and 7.5 milligram? Yes, she does. Is she a frequent user? Well, this is the first time she's came to us, but I would probably say, looking back at records, yes, she is a very frequent user in primary care from the other practice. So with this in mind, can I say with a good certainty that this patient has severe asthma and difficult to manage asthma? Yes, I can. I'd be happy to say that. But on that thought, let's just go back over what asthma is. Look at the asthma phenotypes. Just to recap, this is quite important. With type 2 inflammation, we can either see that with early onset or late onset patients, and it's predominantly eosinophilic driven. The biomarkers for this we can actually check. We can look at Th2, IgEs, eosinophils, and also FeNO as well. So these are some of the things I might want to look at with our patient Bernadette. In non-type 2 asthma, it's a bit more blurred because this is usually driven by neutrophils. Sometimes you'll see the patient being obese. The biomarkers for this are IL-8 and IL-17, and predominantly neutrophilic driven. So you can see the two differences there. And this is where we need to understand the basics of this. And it's really important when it comes on to biologics, as we'll see later. So if you remember, at the time of initial presentation, Bernadette was symptomatic, and that's a priority for us to treat that. So by doing so, we'd give her 40 milligrams prednisolone for 5 days and made sure we had a follow-up appointment in a month's time. The plan was to perform more tests and to consider referral, even at this stage, to consider referral to secondary or tertiary care. Because I'm looking at Bernadette and I'm thinking, look at all the medication she's on. Her inhaler technique's great. She does use an inhaler and she uses it regularly, but she's still not getting controlled. So I'm thinking at that stage, I might want to pass Bernadette on. Even this is like the first or second time I've seen her. At the second time I've seen her, we're doing a RAS test, tested positive for house dust mite. And I'll be honest, a lot of patients do. Also, she showed positive for a certain animal epithelial mix and food mix. And she did mention to me that the previous house she lived in, one of her housemates had a cat, but because she's moved to the area now for a new job, she does not have a pet with her, so that might have been an issue, but at least it's been removed now. Her pheno after second presentation was 34 parts per billion, which is a significant reduction. Her peak flow, now that she was asymptomatic, was 490 litres per minute. And it's really important when we're writing a personalised asthma action plan that we do this knowing what the patient's best peak flow would be when they're asymptomatic. So using that, I wrote up a personalised asthma action plan for Bernadette. Looking at her eosinophil count, her blood eosinophil, it was 120. It was previously 620 when she wasn't on steroids. Well, she wasn't on treatment dose steroids. She was still on the regular maintenance course. But even with maintenance course, she was still 620. Her spirometry, when she came back to see us, showed a big increase. 79% now was an FEV1. But the ratio was still kind of bobbing around that 0.7. Her ACT went from 3.8 to 3.2. Now, we would say that anything that changes more than 0.5 would be clinically significant. And here it is, it's 0.6, but it's an improvement, but still 3.2. 3.2 is not indicative of good asthma control. And her ACT has jumped a couple of points from 12 to 14. So she's a little better, and that's all I would say. We're not out of the woods. We haven't managed everything. She's just a little better. That's all we can say about her. So what is important with patients in asthma is helping them to understand what their asthma is and helping them with and being involved with the decision-making process. Bernadette's an intelligent woman. She's degree educated who understands that asthma can lead to hospitalisation and it can lead to death. But most importantly for her, it can lead to time off work. And that's not what she wants. She's also concerned that the number of oral corticosteroid courses have caused her to gain weight. And I can understand that. The long-term risks of oral corticosteroids were explained to her. And she understands that oral corticosteroids are not the panacea for asthma. She knows that we need to get it controlled and done in a different manner. Her personal goals are to remain out of hospital, ideally asymptomatic, to lose weight and regain a degree of fitness and hopefully enjoy her new dream job in IT. She's now a partner in her own healthcare and she's fully collaborative in care. So she's a kind of great patient, and I love dealing with Bernadette because we both know the journey we want to go on. We both know the destination, and she's more than happy to come with us on that journey. But the problem being is, as we mentioned there, we're still not out of the woods. We've optimised the inhaler therapy. She doesn't smoke. We've done everything we thought we need to do for Bernadette. We've got her on high-dose inhaled corticosteroids with her LABA and her LAMA. She's still on that 7.5 milligram prednisolone daily, and that really we need to keep her on that until we know that we're definitely out of the woods. But she's still not fully controlled. She's not where she wants to be, and she's not where we want her to be either. So what next? We've removed the potential triggers, so that could have been the cat that she had with her housemate where she was before. And I'll mention just a minute that her new office space is the air conditioning in there is managed by a HEPA high purity filter, which is great. So if she's got any hay fever at all, that gets removed out. Her inhaler technique was optimized, so we made sure that she's holding her breath just that little bit longer to make sure for all medication can be, what possible, can be absorbed. The pharmacotherapy was optimized, so we combined the multiple inhaler triple therapy to single inhaler triple therapy. And she's fully collaborative with me. She wants to engage with me. She wants to do it. So where can I go? That's the big question. There is a percentage of patients, no matter what we do in primary care, we still just won't get it for those patients. And that's nothing wrong. There's nothing wrong with that. Often we feel that it's a treatment failure, but it's not. We've done everything we can. We then need to pass Bernadette on to a specialist, either secondary or tertiary centre. So when we do that, she's an ideal candidate for that because we've done everything we can, and we have to stress that everything we can in that respect for Bernadette. And at that point, I would also mention that even though I wouldn't be prescribing biologics, that she might be considered for a biologic pathway as well. Usually biologics are initiated and supplied from secondary or tertiary care centres. That's not something currently right now in most countries that you would do in primary care, but it's something to be considered for, because I'm looking at what Bernadette's got and I'm seeing that really we're not getting any benefit from it. So what are biologics? And just to give you a wee insight to it, I'm not going to bore you with them, but I'm going to give you a slight heads up because they all work slightly differently, and you can understand then why then the decision in secondary care would be chosen for one biologic over another. So there's a couple of biologics available. The first one I'll mention is omalizumab, often referred to just as OMA. And that works on binding to IgE antibodies receptors. So if you've got patients that have got high IgEs, either total IgEs or specific, this might be useful for those patients, and that might be the reason why that was chosen. The other two I've added in here are mepolizumab and reslizumab, and they work specifically on eosinophils. Now, mepolizumab can be given subcutaneously, reslizumab has to be given intravenously. The downside about that is the patient would have to go into hospital maybe every month for that. But these work on eosinophils, not on IgEs. So if you've got a patient with high eosinophils, probably going to be a candidate for mepo or res. Benralizumab, this is quite different. Not only does it work on eosinophils, but also works on basophils and some mast cells. So you're seeing that kind of other aspect to it as well. But bear in mind it does work on high eosinophils, and I've seen some patients actually have their eosinophils virtually depleted, nearly down to zero. Dupilumab is another one. This one works on IL-4 and IL-13 and the cytokine-induced responses, including release of pro-inflammatory cytokines and chemokines on IgE. The strange one with this is because it doesn't work on eosinophils, you can see that whole shift of other inflammatory mediators pushing those eosinophils in the lungs back into the blood. So as a result, you'll see a higher or a significantly raised blood eosinophil count when we're on dupilumab because of that. But it's nothing really to worry about. It probably peaks after about 20 weeks on there. There is also a new mab that's on the market now. This is tezepelumab. This is quite different. And the best way I can explain this to you is if you think about, say, a bucket of water, and the great Professor Brian Lipworth in Dundee explained this to me. If you think about a bucket of water getting filled with a tap, and you have holes in the bottom, say the holes in the bottom would be IL-4, IL-5, IL-13, and IgEs. We need to block these ones, the holes at the bottom. Now we can block the holes at the bottom, the hole in their bucket getting filled up, or we can actually turn the tap off that's filling the bucket up, and that's what tezepelumab does. It inhibits TSLP, which is an alarmin. TSLP stands for thymic stromal lymphopoietin, and inhibits the initiation of that type 2 inflammatory response from the innate ILC2, which is essentially acquired, non-acquired, the innate and the type 2 acquired immune response, and possibly also the neutrophilic aspect of it, of asthma as well, which I kind of didn't mention too much of, apart from the non-type 2 inflammation. But without wanting to go into too much detail, I've got a really simplified diagram of where they work. So without wanting into too much detail, but just to give you a little bit of an understanding, of where biologics act. Let's start at the very top here with tezepelumab. That's the one I said that switches the tap off at the top. And you can see if we're doing that, we're affecting the whole downstream mechanism. The other two we mentioned with mepolizumab and reslizumab, these are working on IL-5, which works on the eosinophils and type 2 cells as well around here. And benralizumab is the one that's specific around here, and that works to block eosinophils, but also causes apoptosis. It causes the eosinophil cells to be disruptive and to literally denature. The one down the bottom here, dupilumab, that's the one that actually can force everything back through eosinophils and ironically raise the eosinophil levels. If we're blocking everything here, this whole process has to go back through here in this cascade pathway, and that's why eosinophils start to increase. The one that's really unique and works on IgEs is omalizumab here as well. So you can see there they all work very, very specifically. There's no particular one for patients. I've seen patients that we would think would be ideal for one particular monoclonal antibody therapy. That's a mAb. And actually they don't respond to it. They respond better to something else. So we can do our best shot at it, but sometimes it doesn't always come out the way we want to. So just to have a quick overview and review, in Bernadette's new workplace, it's environmentally controlled with a high efficiency particulate air filter and air conditioning. That removes out the pollen in the air. Her new accommodation is outside the city. She can go out for nice, beautiful walks. She doesn't have the cat from her housemate that she had before. And wonderfully, the tertiary centre that we asked to have consider for biologics, they responded and they said that she is a suitable candidate for biologic therapy, and she was put on the pathway for treatment after a consultation in secondary care with her, and she was explained of what biologic therapy is. I had talked to her about it. I said, don't hold your hopes for it, but they gave a better job and they explained to her what it was. So, we're not going to say what medication she was put onto. That's not relevant here, just the fact she was put onto a biologic. 3 months after commencing biologic therapy, look at the difference in Bernadette now. Her FeNO was 23 parts per billion. Her blood eosinophils were 35. Maybe if you've listened to what I said before, then you can understand why that's so low. Her FEV1 has certainly increased. Her FEV1 to FVC ratio has moved up beyond that 0.7, 0.69. It's above 0.7 now. And if you look at Bernadette, she's such a happier person. She was not the same person I saw first when she came in from that previous practice. It had changed her life. And that's one of the things she did mention to her, that she's now been able to go to the gym. It's not affecting her life at all. She's a totally new person. So in summary, it's important to understand that even with the best inhaler technique, even with the highest ICS dose and the patient using it every single day, not forgetting a dose, there will be a cohort of patients that will not fully respond. And these patients are ideal patients for a consideration for biologic therapy in a secondary or tertiary care centre. But remember, even with our severe asthmatics, there's a cohort about 5 to 10% that would be considered for biologic therapy. A lot of our severe asthmatics or difficult to manage asthmatics, we can actually manage the asthma by getting the basics right, getting inhaler technique correct, making sure the patient's using it, getting the right pharmacotherapy, removing triggers. Getting all that right first might even prevent the patient having to go on to biologic therapy. And that's our job in primary care, getting the basics right. But when you're referring a patient onto specialist care, don't feel it's a treatment failure. We've done everything we can and we're still not getting anywhere. However, when we're considering severe asthma, it is important to have done everything we can in primary care first before that. Specialist referral has to be done in a timely manner. And in fact, the first presentation when I saw Bernadette, I'm thinking I had in the back of my mind she could be a good candidate for this as well. What I wouldn't do with Bernadette, was sit on this for 5 or 10 years and then think, well, maybe she should be with that. We want to refer in not too early, i.e. we need to make sure we've done the basics and we've done everything we can, make sure they're all performed, but also not too late that the patient's ended up with fixed airways disease, because we're not doing the patient any benefit at all. I have a good wee kind of story. It's based on Goldilocks and the Three Bears. When Goldilocks ate the porridge of the bears, one was too hot, one was too cold, but one was just right. And that's how I talk about asthma referral to secondary care. Don't refer in too early. I work in secondary care as well as primary care, and I see some patients that get referred in that haven't even had their inhaler technique checked, that haven't had their medication optimised. I then see the flip side of it, that patients who have had severe or difficult to manage asthma, and they've had that for 5 or 10 years, they've now ended up with fixed airways disease, that if we'd seen this patient 5 to 10 years earlier, we could have made a difference to that patient's life. But the key is referring in just right, doing everything we can in primary care, and hopefully now with all the tools and the desktop helpers we've got at IPCRG, you'll be in a better place to identify that cohort of patients, to do the best you can, and then when you reach that limit of care, to know when to refer on to them. So I did mention before that I would have the QR code. The QR code's there again as well. If you want to scan that, that'll take you straight to the IPCRG website and the page with the desktop helper. What I would say is have a look at the other desktop helpers we've got at IPCRG. There's a wealth of knowledge there as well, and it's the kind of document you could read when you're having a cup of coffee at work. If you found this useful, please share it with other colleagues. Come back and see us for other updates as well. But thank you very much for joining me and allowing me to take you on the journey of Bernadette and her difficult to manage asthma and how she managed on to get onto biologics. Thank you.